Good morning, everyone. My name is Stephanie Romano, and I'm one of the regional paramedic educators with Base Hospital. Welcome to one of our webinar presentations. If you're new to the webinar setup, what you'll see is a PowerPoint presentation in the background, and you'll hear some of us doing a voiceover on that PowerPoint. We'll go through the presentation here on the ECC updates. Presented by Dr. Michael Llewell, who is our Regional Medical Director, and Dr. Matt Davis, who is our EMS Fellow. You'll also have our Education Coordinator, Dave Usich, chiming in every once in a while to answer questions. So once again, if this is your first time with a webinar, you'll see a control panel on the right-hand side of your screen. And on that control panel, you'll see several boxes. One of them will be a questions or a chat box. So if you happen to have any questions throughout the presentation, feel free to send those to us. We can either present those questions, or if you happen to have a microphone on your computer, there's a little hand icon on your control panel. If you click on that hand icon, we'll see that as if you've raised your hand, and we can actually let you speak in the webinar and ask your questions that way and get a little bit of discussion and feedback. So again, if you have any questions, either raise your hand or type them into our question or chat box, and we can do those throughout the presentation. And just one more note, if there happens to be a group of you watching the webinar, but you've only registered under one name, send that to us as well in the chat box, and we'll make sure to get your attendance record in the webinar. And so without further delay, here's your webinar on our ECC updates.
Thanks very much, Stephanie. It's Mike Llewell here and Matt Davis, and we're broadcasting from the London office of the Southwestern Ontario Regional Base Hospital Program, and we're just being joined now by Severo Rodriguez, who's the program manager, and we're going to have a discussion this morning surrounding the update from the American Heart Association with regard to emergency cardiovascular care updates. So what I'd like to talk about today is I'd like to summarize some of the recommended changes to the actual guidelines as suggested by American Heart. And our purpose in doing this today was to be able to have paramedics understand when we place evidence into practice. So American Heart Association may come up with all kinds of recommendations, but what recommendations actually make it into your directives, and how does that change what you do for the coming year? Unfortunately, a lot of the recommendations that are made may apply to some settings, for instance, an ICU setting or an emergency department setting, but how do we apply those directives to a primary care paramedic or an advanced care paramedic who's by themselves in the field running a code? Because certainly art line measurements and CBP measurements and some of the things they talk about in the actual guidelines clearly will not apply to the pre-hospital care environment. So my purpose and my thought behind today was have a discussion as to how we place evidence into your practice, but I really want people to understand that what you do today at this moment in terms of your directives after this presentation is the exact same thing. Your directives will have not changed after today, but this gives you a glimpse as to how we both incorporate evidence into practice, but also potentially gives you a glimpse as what may be coming down the pipe for the coming year. So although you'll see recommendations and maybe even some suggestions of what the new directives will hold for you in the coming year, until you're officially trained through the base hospital recertification day, nothing changes in your protocols. I want to make sure that's absolutely crystal clear. So without further ado, what we're going to do is we're going to go from one recommendation to another, and they're not in any particular order, and I'm hoping to generate some discussion around each one of them, because some of them may be pretty anticipated, and you may have actually heard about them through some of the discussions with your colleagues, and some of them may be new to you, so maybe there'll be some good discussion that can follow. So as Stephanie mentioned, any questions, just feel free to put up your hand. So we're going to walk through CPR, we're going to walk through cardiac arrest and post-arrest. We're also going to talk about what's new in acute coronary syndromes, and then finally the specific algorithms like tachy and bradycardia, and even some things that apply to the BLS manual, such as first aid and special situations. Although base hospitals don't normally edit what's in the BLS manual, some of the new evidence requires some physician oversight and input into that, and we certainly can make recommendations to the Emergency Health Services Branch of Ministry of Health, and if they incorporate that into the BLS manual, then they do. So I've heard a lot of discussion about this, sequences to become CAB, not ABCs. And after years of talking about ABCs, which is my GI colleagues used to say that's airway band-aid, call somebody, but it's actually airway breathing circulation. All of a sudden it's gone to CAB. And what we mean by that is on initial resuscitation, it's not that we ignore the airway anymore, but when someone collapses from a suspected out-of-hospital cardiac arrest, we know that compressions are so important that we want to not delay the onset of compressions. So the first 2 rescue breaths, potentially, after all this time with your head lift and chin tilt and your normal adult BLS principles, if you provide those 2 rescue breaths first, we may delay the onset of compressions. Plus, we know that people actually have agonal respirations initially, so they may appear to actually be breathing. And those agonal respirations may delay even further, if they seem to be breathing, the actual onset of compressions in CPR. Therefore, the sequence will now, for the first cycle, will be go right to compressions and then focus on airway and breathing as you move ahead.
And that's very important too for the layperson. The concern was that the thought was the airway steps were very difficult for the person who had no medical training. So the recommendation now is if a person appears to be having struggling breathing, just start compressions.
Absolutely, and we'll talk about some of these atypical presentations in people's collapse may actually delay further the onset because people may not recognize the actual fact that this person's arrested, because a lot of times when people collapse, they may actually have a seizure or some other underlying finding. And it's a third-party caller that makes the phone call, so therefore all of a sudden 911 gets activated, a crew goes out, code 4 to see what they think is a seizure, and actually it winds up being someone who's arrested, and we may not recognize that. So last night I was working in the emergency department, and I overheard one of our paramedic students talking to one of the nurses about how it's cabin, it's ADCs, and it's kind of funny because one of the nurses said, yeah, I don't think that's going to affect you much in EMS, and it's kind of funny how we were talking about that this morning, and I'm like, I think it's going to affect us somewhat. Focusing even further on that exact topic is that you're absolutely right. Seizures and other atypical presentations, such as agonal arrests, may delay time to activation of 911 or also performance of CPR. And this is a real life thing, because it was funny. I was on a ride along one day with a paramedic, and he was talking to me about seizures, and I was trying to get him to discuss about any recent calls he was on. And he was very, very reasonable and said to me, you know, I've had a problem with seizures in the past while. I've seen 3 or 4 seizures, and all of them wound up arresting. And it was only through discussing that actual case that we discovered that, well, most likely what he actually witnessed was the patient arresting, and then because your brain's not smart enough to figure out why blood and oxygen is not coming to it, it just starts to seize. But actually the person had a cardiac arrest, seized, and then had, and so it wasn't the seizure that caused him to arrest, it was actually the arrest that triggered the seizure. And that stems to exactly what we're talking about in the field, that we see people go down, you walk in with the blinders on thinking you're seeing a seizure call, and you may not apply the defib right away. So it's kind of funny in the emergency department, I'm sure, Matt, you do the same thing, when all of a sudden they call for a physician and a patient is seizing in the bed, we go for the defibrillator, whereas everyone else goes for the Ativan, but he doesn't need Ativan if they're arrested. Further emphasizing the role of compression, it's recommended that lay rescuers should not even attempt pulse checks and not interrupt CPR until EMS arrives or an AED is applied, which is a real paradigm shift and maybe part of the hesitancy in terms of implementing CPR that some patients have, because they're worried about doing harm to patients. So if a lay rescue arrives someone and sees someone's collapsed, see someone that is collapsed, it's recommended that they forget about trying to assess pulses, because I'm not sure if you've ever watched a layperson trying to take a pulse. They don't know where to look, and they're filled with adrenaline. They may be feeling their own pulse. They may be somewhat reticent if they can't find the pulse to begin CPR. The bottom line is the pulse should be quite easy to find for a trained rescuer, but for an untrained rescuer, it's very anxiety-provoking. If someone it looks arrested, is not responding and not breathing normally, then the advocation by the American Heart Association is to go right ahead and begin compressions until EMS arrives or an AED is supplied. If you look at some of the centers that have good bystander CPR, such as Seattle, they have an enormous out-of-hospital discharge, survive alive with good neurological function, discharge rate for witnessed arrests in ventricular fibrillation, because they have such a high bystander CPR rate. But in those situations, they teach CPR at high school, and they have even 40 and 50% of people are CPR trained, whereas a lot of our series in urban centers in Southwest Ontario tend to be 15 to 20% at best. And I think we hover here locally around 13 to 15%. So out-of-hospital survival, one of the big links of survival to discharge is bystander CPR. Now, Pulse checks are a delay and are not accurate and should not be not be any longer than 10 seconds. And what I found interesting about this recommendation is that's kind of what we do. I mean, if you're going to do a pulse check, we do tend to limit it to 10 seconds. What I found interesting is that currently in our BLS manual, we talk about that, and actually in our advanced medical directive, is in the hypothermic arrest, we allow pulse checks and advocate for up to 45 seconds. And it's quite prescriptive in the AHA guidelines that even in hypothermia, we may need to change them and leave it to 10 seconds. Because if you're struggling to find a pulse for 45 seconds, well, chances are there isn't a pulse there. And if you look at the perfusion rate of your head when you stop compressions, it's amazing how perfusion to your brain drops off dramatically as soon as you stop any kind of compressions. And that's why the focus is actually on time on the chest. And that's been around since the 2005 guidelines. I'm not sure if Matt remembers the 2005 guidelines or before the 2005 guidelines, but at that time we used to do shock, 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 and we used to do all, yeah, everybody shock, shock, everybody shock. It seemed like we never did CPR, and now it seems to be all about CPR. So it's really a tremendous shift back to time on the chest. CPR providers that switch every 2 minutes. Now, I know that many of my EMS colleagues will scoff at this because what happens if you're a PCP or an ACP in a rural environment and you are it? There is no fire. You are looking at a 25-minute transport time and you're looking at trying to switch a provider every 2 minutes. And that's what I was trying to allude to this morning is that a lot of these guidelines are great and they work really well when you have 12 people in a resuscitation room, but they don't, or you have a good fire response with 4 or 5 firefighters there to help you with compressions, but this does not apply necessarily to when you're a lone rescuer. Especially we know that if we look at CPR telemetry devices, we look at quality of CPR, the CPR that gets performed in the back of the truck on a moving ambulance by a lone rescuer, it's abysmal because simply how can we get good CPR when you're bouncing around in the back of the truck, and we definitely know that you fatigue over time. So this is a role where some other devices, such as automated CPR devices, may play a more of a role in the future, especially in long transport times. As I say, any questions you have, feel free to pop up because we can actually address them online as we move. So for those of you that have been, the debate for the last 5 years has been, should we be doing CPR before defibrillation or should we actually do immediate defibrillation and then CPR? And we always focused on, is this a witnessed or unwitnessed cardiac arrest? And it's interesting that we actually there's actually been a lot of research looking at just that topic, and unfortunately CPR before defibrillation did not actually improve outcome in unwitnessed cardiac arrest. And so the recommendation has come to, and as again, I want to be very clear, the directives don't change at this point. But in practical terms, if it's an unwitnessed cardiac arrest, you normally did 2 minutes of CPR up front, at the defib bond, and did your analysis. But now they're saying, well, really, delaying the analysis it doesn't make that much of a difference. But in all practical terms, if you arrive on scene to an unwitnessed arrest and your partner immediately begins CPR while you get the defib, if you actually time that interval by the time you get the defib on and perform your first analysis, it varies between 1.5 and 3 minutes. So guess what? Even if you randomize to CPR ahead of the defibrillation versus immediate defibrillation and unwitnessed, you're talking about the same thing. You're really talking about 2 minutes. And that's pretty much what the recommendation says. It says get CPR going as soon as you can, and getting the defib while you're getting the defib attached, and then perform analysis. And that usually means about 2 minutes. And that may or may not be what the recommendation then becomes. Clearly, in the witnessed arrest, and we know that EMS witnessed arrest is a much higher survival and a much higher incidence of VF, it's immediate analysis and immediate defibrillation if that's applied. For those of you that worked in a ROC center, and a ROC center is a Resuscitations Outcomes Consortium, there is the ITD device. And the ITD device it's a confusing little device that sits at the end of the endotracheal tube. Yep. And Matt, do you want to sort of walk through what the ITD does? Or the ITD, basically what it does is it increases the intrathoracic pressure and enhances the method by which the thoracic pump model of CPR works. So as you're doing compressions, in theory it actually creates better coronary backflow and better coronary perfusion pressure. And so we used to put these little devices on the end of an endotracheal tube and think that these made a difference, or an SGA, and see these made a difference in terms of survival. Unfortunately, the ROC study showed that the ITD made no difference to outcome, both neuro intact discharge, but it did improve initial ROSC and initial short-term survival. It's interesting, while we were at the latest update at the National Association of EMS Physicians, there is actually a trial which is just recently released in the Lancet, which shows that if you combine this ITD with an automated CPR device, you actually have an increased likelihood of survival. But that's brand new literature, and that's not necessarily made it into the guidelines as of yet, but it does show some promise. Speaking of automated CPR devices, the low distributing band mechanical CPR device, which is many systems in Ontario do use, unfortunately showed no outcome in 4-hour survival. And initially on the trial, which is called the ASPIRE trial, it showed worse neurological outcomes initially. But nevertheless, anytime you look at a trial, it's important to look at, is this the way we use these things in our current practice? And the debate after this trial came out was that the way they randomized, the way they used the automated CPR device, the low distributing band device in this trial, it was randomized late, and it was actually potentially assigned to effectively give later CPR, later onset of compressions, which may have falsely led to the worsening neurological outcome that was shown. So it's basically, it was used in an inappropriate fashion in the trial. So there's a new ongoing trial, which is a bit larger, and that's hopefully going to answer what the role of the low distributing band is in the setting of cardiac arrest. That doesn't speak to some of the other advantages necessary of the mechanical CPR device, which is providing good CPR and not fatiguing the lone rescuer, but also providing a CPR in the back of a truck when we know that you're not comparing optimal CPR to low distributing band CPR. You're comparing any CPR to low distributing bands, and really, quite honestly, in my mind, when you have a strained paramedic in a seat with their seatbelt on and the low distributing band providing good CPR, that's safer and probably more effective than actually a paramedic trying to bounce around the back of the rig and do their own CPR. So the bottom line with the low distributing band, and I was actually talking to one of the EMS operators in Ontario outside of our region the other day just about this same topic. The jury's still out on how this is best applied. And maybe for the next update we'll have some pretty solid evidence of this, because there seem to be some conflicting answers.
And it was interesting with this trial was the ASPIRE trial, and the sites had 3 different methods at which they could apply the auto pulse. And in the study, all the sites actually chose the exact same protocol, and things were going well with the trial. But halfway through, one of the sites changed the protocol and went to one of the other 3 recommended protocols, and after that time they started seeing worse outcomes in these patients. So that was one of the big critiques of this study. So it is being done again on a larger scale with a set protocol that they're going to follow.
On a much smaller level, with one of our local municipalities, we actually did a retrospective analysis. Do you want to comment a little bit about that, Matt? That was presented in the National Association of EMS Physicians in January.
That was Samir Mal's project, and he found that, looking at Oxford's data, that the autopulse actually did show some benefit to hospital ROSC, but there was not enough data to actually prove that it actually affected discharge from hospital with intact neurological function. So it was a smaller project. It wasn't powered or didn't have enough people to actually prove those outcomes, which we're really concerned about, and that is actually leaving the hospital and getting back to your life and going back to your job. And that's what's the important thing with these outcome points, is you don't necessarily just want someone to come back to life and then spend a week, a month in the hospital just to die. You want them to be able to get back home to their family, their life, their job.
Precisely, and it's funny, if you look at all the different studies looking at out-of-hospital discharge, so many of them show increased ROSC, but not increased survival to discharge. And but you always wonder, and always tantalizing me think, well, if you just add in all the studies that show ROSC, maybe we need to have the perfect resuscitation should be all these different trials that have ROSC and see if they actually make increased survival. But unfortunately, adding it all in like that with a perfect system just is not really feasible. Everyone uses different machines, different protocols, different techniques, but the best people looking at that, I think, in terms of consistency, probably are the ROC investigators, which we continue in some areas within our region to be participating in.
Okay, Mike, Matt, just before we move on, a couple things. We know that Samir did a lot of good work on the auto pulse, but there's some services now looking at the Lucas device. So is there anything that we want to add in, any thoughts that we would have? And I was also thinking this is a good time. We've had a number of people who signed in maybe 2, 3, 5 minutes after we started. It might be a good time just to put in our disclaimer again as to the actual purpose of this presentation today.
Oh, sure, absolutely. So let's go with the disclaimer first. So for those of you that signed in late, welcome to the webinar on the American Heart Association guidelines. The big important thing to take from this is to know that we're talking about how we blend evidence, which is a recommendation from a large entities such as the American Heart, into field protocols that the paramedics are going to use on a day-to-day basis in Ontario. And our purpose in doing this is to show you the process we go through. What you do at 9 o'clock today is what you're going to do at noon today. Nothing changes with regard to your actual local medical directives and your regional medical directives. Those stay absolutely the same. So anything you see here is what may be implemented in the next go-around of research, but does not change what you do today. But I thought it might be interesting to see what kind of debate is happening in the scientific literature and how we blend this in, how we change this evidence into actual practice. So don't change what you do by the end of today, if that cannot be any more clear. I'm worried that they said, well, this sounds like a great idea, but I heard about this morning on a webinar, so let's try this afternoon. In terms of the Lucas device, I don't think I'm certainly not aware of any specific literature, one compression automated device versus another. And certainly, I don't want us to be seeming that we're endorsing one product over the other either. Base hospitals steer far clearer recommending specific equipment devices, but nevertheless, these are just evidence pieces that are referencing certain devices, therefore, and they're mentioned by the guidelines, so we mention them here, but it's not that we endorse one over the other. Good question, Dave, thanks. So this is an interesting recommendation that dispatchers now, for people that seem to have suffered from an out-of-hospital cardiac arrest, given the emphasis on compression, should be providing instruction of hands-only CPR, as well as advice on rescue breathing for pediatric or suspected asphyxial arrests. Now, this is interesting because one of the things that prevents rescuers, untrained rescuers, from performing compressions is because in the olden days we used to ask them, are you breathing, are you breathing? And many people, when they're arrested, will have this agonal brainstem breathing. They basically open their mouth and make this big gasp. And if they were having that breathing, then potentially that in the past would have withheld people from actually starting CPR. So now, if they have abnormal breathing, then the recommendation is to begin hands-only compression, because we also know that in the setting of lay rescuers, the need to go ahead and advocate for rescue breaths may be another reason why people are reticent to begin CPR. So if you just start CPR itself, just compression only, as you compress and decompress the chest, you will still get some actually passive ventilation of your lungs. So the recommendation for untrained providers is to actually go with hands-only CPR, and dispatchers are primarily supposed to recommend that. What I don't understand from this recommendation myself is how do you tell someone that only do this for suspected cardiac arrest, not for suspected asphyxial arrest? Because, you know, in theory they're talking about someone who's a hanging or a drowning here, but, you know, trying to tell my mother and ask my mother, for instance, hey, do you think he died from asphyxia? My mother would be like, I don't know, don't tell me. But certainly, with regard to pediatrics, the recommendation is since pediatrics require ventilation, the hands-only compression are not necessarily made it to the recommendation for pediatrics yet.
You may also notice throughout the presentation there's Class 1, Class 2 recommendations, and some of you may be wondering what the difference is between the different classes. And when guidelines are released, the people who sit down and look at the research come up with set definitions of their classes. And usually a Class 1 recommendation means this is the strongest evidence, it's good quality research, randomized control trials, and usually a Class 1 is something where there's a lot of evidence supporting. When you start getting into the lower classes, there's less evidence that's really strong, good research that says, you know, this is what we should be doing. So when you see someone with a Class 1, usually there's quite a good amount of literature and solid evidence behind it.
It's a very, very good point, because I never thought about the classes. That's a very good point to bring in. What I found interesting too is we have all these restrictive protocols for aspirin administration, and we get lots of questions through our frequently asked question list about the role of aspirin and when should we give it. And yet I found it quite cavalier that all of a sudden it thrust into the guidelines is that pretty much EMS dispatchers actually provide instructions over the phone for anyone that sounds like they have ischemic chest pain to take a dose of aspirin.
Right.
I'm pretty surprised that the patients went ahead and did that, but nevertheless, that is a recommendation in the guidelines. So whether or not that gets placed into dispatch protocols, I'm not so sure, but it's pretty strongly worded. Given how tightly we control aspirin use, is kind of interesting. Specifically with regard to cardiac arrest, one of the recommendations I thought was interesting is that resuscitation should be performed where the patient is found, and that's an ongoing debate we used to have. And clearly, this is a bunch of physicians making this recommendation, not necessarily paramedics that are in the field and find patients wedged between the toilet and they can't get out of the area and they're stuck down and it's a tight space to work. That's not what we're talking about here. We're talking about sometimes we move patients to, but every time we move them, there's going to be a delay to defibrillation. So where it is possible to hook up the defib, that's where we should be analyzing the rhythm, because that may delay or at least hook up the defib, begin CPR, and perform an analysis. Clearly, you want to avoid using the defibrillator in water, but specifically, we hear a lot of people that are collapsing outside and all these days with shoveling, and the American Heart Association actually say that you can actually use the defib on snow and ice, but you're trying to avoid it in people that are immersed in water and in puddles and that type of thing. And that's a question we get quite often. But it was interesting how the American Heart Association has weighed in on that specifically.
Again, the first point there I think weighs in with the change to the CAB when their idea is to perform resuscitation where the patient is found. If you're moving the patient to get to the ambulance before you start your resuscitation, well then the quality of compressions as you're on the move is not going to be nearly as good as if you're going to be doing it on a solid floor. So I think that may be tied in a bit with that.
And it's funny how so often patients are found in the bathroom just before with their cardiac arrest, because just before they have arrest, oftentimes they have this enormous vagal tone, and they get this enormous feeling of impending doom, which in your brain you actually recognize as the need to have a bowel movement. So just before, again, people arrest, if it's not a seizure, they actually sometimes feel this overwhelming urge to have a bowel movement, and they go to the washroom where unfortunately they have the demise. So I always think about that as just before someone arrests and they feel the need to have a bowel movement, it's kind of like the hand of God on their shoulder saying, look, you're coming with me and it's a long trip, so why don't you use the facilities before you go, because it's going to be a while.
And when I have a sick patient in emerge and they say that to me, then my bowels start going as well, because I know it's not a good thing.
Well, yours gets tighter and theirs gets bigger.
That's right.
All right, so there goes the appropriateness of our webinar right there. My program manager is rolling his eyes at us right now. So, okay, let's move along. So, cardiac arrest. Avoid placing pads directly over an ICD, which is an implanted cardiac defibrillator, or a transdermal medication patch. And I want to be very specific. These are American Heart Association guideline recommendations. What you do today is not what you do, what you do today before this webinar is what you do after this webinar. These are the recommendations that come from the American Heart, but you still follow your manufacturer prescription for your defib operation, and if nothing changes with your current practice in that regard. But it's just kind of interesting how these recommendations from the American Heart transcend everything from first aid all the way to actually how you apply a defibrillator. So I thought these were quite interesting. For those of you familiar with the TOR, and throughout our region we have various types of TORs which are actually at this point not actually consistent, and we strive for consistency, and I suspect in the next round of guidelines we are going to have consistent TOR rules, both from trauma as well as from medical. And I'm also hoping that actually we may see a simplification of the trauma TOR rule, which is in a Southwest initiative as well, but you have to wait to see the new directives when they roll out, but that may be coming down the pipe. But for now, the BLS and ALS TOR rules should be implemented, and that was a recommendation from the American Heart. And what this means is that we know that transporting cardiac arrest patients is not without risk. There's an increased likelihood for collisions, there's an increased likelihood of injury to paramedics and also other patients, and also the public with fire trucks and ambulances screaming through the city. And through rural roads with bad icy conditions. So we know that if we apply the TOR rule to futile resuscitations, these people, no matter what we do, we're not going to get them back, we actually reduce the rate of transport by 37 to 60%, depending on the TOR rule we use. And the debate is always, should we apply the TOR rule before moving the patient to the ambulance or do it in the ambulance? And ideally, we try and avoid declaring patients dead or pronouncing patients in the back of an ambulance, because that becomes the scene of death. Although, as everyone knows, the new pronouncement of death standard does have specific language for that. Nevertheless, I think we're going to see a common medical tour come through, based largely out of the evidence that has been done in Canada. Which is another interesting thing is, Matt, as we go to these international meetings, we find that a lot of the evidence in the EMS is actually driven by Canadians. And we lend well to this in that most of our systems, like for instance, take the Ontario system, we follow a common set, by and large, of directives. And if we have 1,400 or so paramedics in the Southwest, and the other 7 base hospitals have a similar number, and we're all following the same directives, we have an enormous call volume of patients that are being treated in a similar fashion, which lends itself well to study. So Canadian paramedics should be very proud of the evidence that comes from Canada, because we drive the practice in North America, and that's something that maybe a lot of our paramedic colleagues may not be aware of. This is a Canadian trial of which people in the Southwest were actually involved in the creation, and now it's actually being implemented as an American Heart Association guideline. So congratulations to those of you that have been involved in the study of this. Well, this is for our ALS colleagues. This may be an interesting thing, that atropine is now gone from PEA and asystole. So, Matt, how many times do you talk about, well, should we get up to 3 milligrams and break out the purple box? But right. The purple box is leaving.
It's one less drug to worry about now.
Yeah. Well, think, if the weight of atropine is taken out of the bag.
Yeah, I know.
Oh, we still need our bradycardia. So, shoot. The routine use of sodium bicarb is no longer recommended, which is another thing. In about 3 guidelines ago, you found that everyone got bicarb. If you're arrested, you're acidotic, and therefore if you're acidotic, you need bicarb. But if you're acidotic, meaning that your cells have all converted to anaerobic metabolism because of lack of oxygen delivery, therefore you're making all this lactate, which is lactic acid, which then drops your pH. Your enzyme systems don't work very well, and you become unresuscitatable. So all this thought was, let's give them bicarb, and that'll make them better and bring their pH up. But we actually found that, unfortunately, it doesn't work. And really, the best way to restore someone's anaerobic metabolism to aerobic metabolism is to get their pump working. And so get your pump working by defibrillation and by CPR and by vasopressors to perfuse your head during CPR. So really, the role of sodium bicarb outside of specific clinical indications, such as hyperkalemia, witnessed arrest in the setting of someone with a tricyclic antidepressant overdose. Those type of things would be considerations for sodium bicarb. So I don't think we're going to see bicarb leave the bag, but bicarb definitely is not a first-line recommendation like it used to be in the old guidelines. Now, I found this quite interesting, and this is, I think, that I'm going to hear some of our colleagues scoff a little bit about this from the field implications. Is interruptions in CPR should not be limited to more than, all right, not be limited. Should not be more than 10 seconds for endotracheal tubes, and not at all for supraglottic airways. Well, I don't know. I mean, Matt, you're a pretty good intubator, and I've watched you intubate lots of people, but I don't think you can intubate in 10 seconds.
11 seconds, but not 10.
That's awesome. Yeah. I mean, and I always kind of find it funny because in our training, we work in the emergency department by and large, and it's so easy for us to intubate patients because we have, it's kind of comical actually in the trauma room. We bring the stretcher up to our waist. We have an RT there. We have suction. We have good lighting. We have an array of laryngoscopes all laid out ready for us with multiple tubes with stylettes already prepared for us. We have nurses going for IVs and everything ready, and then all of a sudden, with paralytics on board, we go, I'm going to intubate now, and you intubate. And even then, it takes longer than 10 seconds. Right. It's almost like you drop the tube in. And I remember one of my first ride-alongs with our ALS coordinator. I'm sitting in someone's kitchen, and the guy needs to be intubated, and I watch him. Immediately in my mind, I'm thinking, well, we just need to raise him up somehow. My ALS coordinator looks at me and goes, you're dumb. And he gets down and lays down in the guy's urine and intubates him on his face in his kitchen floor. I'm like, well, that's why it's hard to do this. And absolutely, so tremendous respect for what's happening in the field with our ACPs with the intratracheal intubation and our PCPs with supraglottic airway intubation. These are difficult tasks to do in the situations you're in. Nevertheless, the recommendation you can see is for minimum time off chest. And I think you can take from this, that's exactly what they're trying to get at, is minimize the time off the chest for the airway, because really compressions are so vital. And I think that's what they're trying to get at here. it's interesting the debate that these recommendations have occurred is because in some situations where they're really big on endotracheal tubes, they're advocating for pulling endotracheal tubes all the way out. That's some of the debate we're having. And people are thinking, well, let's just put in a supraglottic airway in right away, because if airways aren't all that important, let's just go right ahead with supraglottic airway and forget about endotracheal tubes. And there is a rational argument to that. Nevertheless, there's also a rational argument for endotracheal tubes because there are some contraindications to supraglottic airways, and if someone's vomiting a lot, your airway is not necessarily fully protected, and actually you have a higher risk of esophageal injury with supraglottic. So supraglottic isn't exactly the ideal solution for all things, but nevertheless, in terms of speed and time off chest, it is easier to put in before an endotracheal tube. So it's hard to know where the debate will ultimately sit on this, but certainly there's a movement away from field intubations and continuing on the supraglottic airway path. We see this a lot with regard to some of our newer practitioners with regard to our adrenaline's flowing at a cardiac arrest, we're a bag valve masking someone, we may have a supraglottic airway in place, and then we now finally have it and we want to, and we have a bad SAT reading, and we have a bad SAT reading because we're not perfusing our fingers and the SAT's not picking up because there's no flow. And so therefore we want to bag them up and we want to get that breathing going. But effectively what you're doing is when you're bagging them up, you're really decreasing your CO2, and you drop your CO2, you
Decrease blood flow to the brain.
and if you decrease blood flow to the brain, you're
Pooched.
you're not waking up. No, so exactly. Pooched. How do you spell that?
P-O-O-C-H-E-D.
Oh, nice, nice. Well, I'm going to go home and walk the pooch later. So absolutely, you decrease blood supply to your brain and they're not going to wake up. And also, you think about what the metabolic demands are. If you think of carbon dioxide as your physiologic exhaust, if the machine's only running best sort of 30% with CPR, you're not making that much exhaust. So the need to actually ventilate you is not that great because you're not making that much exhaust. So really, quite honestly, normal tidal volume is 12 breaths per minute on 21% oxygen. Now we're giving these guys 100% oxygen. Well, quite honestly, 8 to 10 breaths is all you need. So let's avoid hypocapnia because you're not making that much carbon dioxide anyway. You drop your carbon dioxide, you don't perfuse your brain. And this is all about keeping your brain alive till we fix what's wrong with your pump.
That's right.
And that's really the whole emphasis of management of cardiac arrest. I'm glad they've said this recommendation because this is one of our frequently asked questions. And I think we may see this potentially in the new directives where we're talking about, we get this question a lot. So should I give the amio first or the lido first, or can I give on 1 2-minute cycle epi-N lido or epi-N amio, or what can I do, or do I need to alternate? And the bottom line is you can't go wrong here. There's insufficient evidence to recommend either. So logic would assume the earlier you get the vasopressor on board, the longer it has to work. But also logic would assume the easier you get the antiarrhythmic on board, the easier it has to work too. So if you want to alternate cycles, if it's easier for you to remember that, then great. If you don't want to alternate cycles, you want to give them both in the same cycle, if you have time, then great. There's not a clear recommendation that you must do this in the first 2 minutes. So I'm glad that recommendation came out. And we also know that the role of advanced airway, when to place it, doesn't really matter in terms of the cycle either. So in the last little while, we've emphasized delaying the advanced airway to later on. There are more PCP updates as well. So this just happens to be some of the specific drug therapy which apply more to our ACP colleagues, but most of these recommendations actually deal with our PCP colleagues. So I think we're going to get our way through some of these here in a minute and get back to some of our PCP colleagues. Amiodarone is the first-line antiarrhythmic agent that's been clinically shown to improve ROSC without a hospital administrations for VF and VT. But again, it's important that ROSC is not survival to discharge. And although there was one series that showed amiodarone has higher ROSC than lidocaine, it's not been shown to increase out-of-hospital survival to discharge. So really, at this point, amio or lido are still recommended therapies. And so I know that within our region we have lidocaine centers and we have amiodarone centers. And I think the ROC investigators are actually looking at implementing a new trial looking at placebo versus lido versus amio, because there was a study out of Norway which is very interesting. And what did that show? It basically showed that almost anything, you can basically randomize to no IV medications and IV medications, and there's actually no difference.
The same. They do the exact same.
So that's how they got the ability to get ethics approval for doing a placebo versus amio versus lido trial, because potentially all IV meds don't make a difference in cardiac arrest. And is that shocking? Well, probably not really. I mean, really, the emphasis is on compression and defibrillation. And if you look at the people that survive, they're VF people, they're VT people, they get early defib, early CPR. And the people that don't survive are the asystolics and PEAs, and those are the people that are presumably don't benefit from any medications apart from CPR, really. So one of the recommendations, if a drug is administered in an arrest IV peripherally, it should be administered by a 20 cc fluid bolus. And I read that and I'm like, well, I don't think we necessarily do that.
I can't even remember the last time I saw something that was followed, like giving an epi IV and then followed by a chaser, a saline flush in the emergency department. So.
Yeah, and you know, we tend to open the IV and have it running, so it's at your 20 cc IV fluid bolus, because really the IVs are open. Yep. But then again, I know that a lot of our paramedics are very prescriptive about the, I only start the fluid bolus in PEA, and I don't give it an asystole, but you know, quite honestly, maybe this means that we need to edit our algorithm to be more open, just keeping the IVs open. I mean, what's the worst you're going to do? Put them in pulmonary edema? Right. The heart's not beating. That's a problem. We used to give endotracheal tube medications for a while, and that's still an option available to us, but it's interesting that there's actually some evidence that's coming out that's showing medications in endotracheal tube may actually have the undesired consequences, such as actual vasodilatation and lowering coronary perfusion pressure. So ironically, putting the drugs down the tube actually may worsen things. So it's not still contraindicated, and again, nothing changes in your day-to-day practice today, but it may be that in the new recommendations we may be steering further and further away from endotracheal tube medications. I always find it funny reading cardiac arrest ACRs. It would say 3 doses times 2 down the tube with a 10 cc dilution, and then the next line would be suction for plus secretions. Like I'm going to suck all the epi out of the guy, but oh well. You may have read some of the cooling things, and hypothermia is really an enormous Pandora's box that's come along to pre-hospital and cardiac resuscitation, and it applies both to ACPs and PCPs. And I know that when we partner with Fanshawe, our local college, and we have Fanshawe College Research Day, we talk a lot about who to cool and when to cool and what the evidence is, and I'm not necessarily sure the evidence is all out there for all who we should cool yet. Because like a lot of things, we discover something has a benefit, and then all of a sudden we think it must work for everybody. And so then we cool everybody. And then eventually there's this rationalization of who we actually know benefits from this therapy, and then we pull back a little bit. And that's typical with how medicine works. We get a new gadget, we're like, this sounds awesome, let's use it for everybody. Then we go, oh, it didn't help everybody. And then we go, let's use it for these people. And that's what we're doing with hypothermia, I see. So no randomized clinical trial exists to compare outcomes between hypothermia and normothermia for the non-ventricular fibrillation arrests, yet we still expand that to the asystoles and the PEAs if they have return of spontaneous circulation and they go to the ICU, we cool them. Now, the question is, when should we cool them? And that recommendation is all over the map, because so long as really you have them cooled by 8 hours, that's where the benefit comes from. But we went to a presentation where New York City, for instance, is cooling who?
They're pre-hospital. As soon as they find the patient in arrest, they open up some cool saline on them and start cooling them right away during the actual arrest.
So we don't even know this guy's going to even have a return of spontaneous circulation, but we're pouring ice cold saline into him in New York City. And we talked to the medical director of New York City. Actually, his name is actually Dr. Freeze. We're not making that up. It's Dr. Freeze. And it's interesting that they're always on the edge of this. They're moving ahead and pushing the boundaries and advocating for aggressive use of this. And maybe they're the people that will then design the new algorithms that will say, we need to be cooling these people earlier. But so far, if you look at the recommendations, and it's important maybe to talk about now, these recommendations come on the best available current science. So what is defendable, what's out there now in the current science, and really the current science is that hypothermia, so long as it's started by 8 hours, is reasonable. Now, with that said, we see more and more emergency departments and more EMS agencies starting the cooling process because it's thought that that may have some tangible benefit. One of my favorite questions that I get asked all the time is, should we treat people with low blood sugar in cardiac arrest? And that's sort of a question we get all the time, because we get paramedics that do a blood sugar on someone who's got a cardiac arrest, and they measure a low blood sugar in the end of their finger and think, well, maybe this person should be getting dextrose. But many times these people aren't even diabetic. And so remember, what drops your sugar in diabetes is the oral hypoglycemic you're taking or the insulin. So if they're not even diabetic, why would they become hypoglycemic? And the reason they're hypoglycemic when you measure it in a cardiac arrest is you don't have any blood supply to the end of your finger. And if you poke the finger, what carries the sugar to the finger is the blood. What pumps the blood?
The heart.
The heart.
It's not working.
Heart not working, no blood coming, no sugar coming. So we in the past, we've had medics patch in and base hospital physicians here, oh, low blood sugar, can't confirm he's not a diabetic, give him some dextrose. And really, what's the harm in that? Well, it's interesting that the American Heart Association has actually talked about that post-arrest, patients are actually prone to hyperglycemia. After you have all these stress hormones released and all this epinephrine and all these different catecholamines are given to the patient and also endogenously secreted by their own, that word is endogenously secreted by their own adrenal glands, then that actually gives you a trend towards hyperglycemia. And that actually has been shown to increase your mortality and worsen your neurological outcome. So it's been my feeling that really we shouldn't be giving large osmotic loads of dextrose to patients in the setting of cardiac arrest of dextrose because it may worsen the neurological outcome because you have leaky membranes in your brain and all of a sudden you throw up there an anti-D50 and that's a lot of dextrose and it may actually worsen your neurological outcome. So they actually talk about being able to keep hypoglycemia afterwards or at least keep very tight glycemic control by even giving insulin to these people in the ICU to keep their sugar from rising because thinking that they're so worried about that sugar rising. Well, in my mind, it's a good argument for not giving D50 in the middle of a cardiac arrest, which in my mind, we're treating as a number that's a false number. Because what is that I always tell Dwayne? I always say, if you eat all the food in your refrigerator and then don't do groceries, what happens to the food in your refrigerator? Goes away.
It's adding fuel to the fire.
Mike?
Yeah.
I'm just going to jump in for a sec. A couple things for me just to mention. It's a really quiet group. I haven't jumped in with questions because there really isn't any that are coming in. So I encourage people, either to put your hand up and we can open your mic and let you talk, or if you'd rather, just type in a question and we'll get it addressed. And the other thing is, it's a great webinar going on so far, and I don't want to change the pattern of the flow here. Just giving everybody a heads up, we may run just a little bit past the 11 o'clock mark, looking at the number of slides that we have left here to go today.
We'll talk a little bit faster.
Have another black coffee over there.
All right. Well, one of the things passionate near and dear to your heart, Matt, is the 12-lead ECG, and we see, and this is going to lend well to perhaps what the next webinar we're putting out is the role of the pre-hospital 12-lead ECG and how it influences care. But what we want to be able to do is the recommendation of the American Heart is to have 12-lead ECGs be linked to some sort of ongoing quality assurance plan and through either the EMS service or also through cooperation with the base hospital program, because we know from your study, Matt, that it really does change what emergency physicians do, not just in the setting of STEMI care.
That's right. In the setting of ACS, often the patients, you see the patients first, they're having their symptoms, they're given symptomatic relief, you do an ECG. We see changes on that pre-hospital ECG that we're not capturing in the emergency department. So it is a very important tool for us in the emergency department.
Awesome. Absolutely. STEMI bypass is a topic near and dear to all of our hearts. We're trying to bring the role of the cath lab to patients sooner and do that by bypassing the emergency department, similar to stroke and similar to certain areas within the province already that are doing STEMI bypass. So definitely there's clear evidence that this benefits, but it doesn't benefit everybody. It benefits people if we can get them to a cath lab within within 90 minutes with the balloon up. So symptom onset or time from diagnostic ECG to balloon up should be less than 90 minutes ideally. So really that corresponds to a 30-minute transport time, and beyond that we actually may be causing harm. And specifically in that topic, there's no recommendation as to what the scope of practice for the paramedic should be. So we don't necessarily know if, given the fact you're having an acute MI, maybe the incidence of cardiac arrest and the incidence of symptomatic bradycardia is quite high, maybe we should limit these transports to ACPs. Maybe it is safe for PCPs. We don't know the data yet, and that's something that I'm certainly working on at the level of the province to try and bring STEMI bypass to the most available people as possible. Interesting that we should move to head to PCI for everybody who have an out-of-hospital cardiac arrest. So even if you came in a coma with a ROSC after a cardiac arrest, you should go ahead and have a plasty, which is really a controversial argument because a lot of these patients actually have an irreversible brain injury and may die in the ICU later, and that really harms your stats as a CAT center, which CAT centers are obliged to be able to report their success and failures. And so nevertheless, this is a paradigm shift. Many for the American centers do large numbers of these. So you're now seeing people capping people where they may not have. And that little picture is ideally, I tried to find a stent, but it's close enough. It looks more like a spray. We won't talk about that.
Mike, just before we move on, now this question, the hand popped up. It may be related to the slide just before that, but I'm going to open up the mic.
Hi, it's Jamie.
Hang on, going to get rid of that. Jamie, are you interested in asking a question?
Yeah, I just wanted to double check something with Mike. I had two STEMIs that both been in outside the area. One's one in Kerwood, and the earlier one was in Watford. They both been. The one in Watford was like 60 kilometers or so from UH, and the Kerwood one was approximately 50 kilometers. Both times I bypassed Strathroy Hospital. They're both big elevation, big ST elevations, and they were both infarcting, and I was pretty scared. I just want to confirm that it's still okay. Both times I talked to the cardiologist. He said, yeah, bring him in, but when I bypassed the Strathroy Hospital, it was still very concerning, and I just want to double check that it is the appropriate thing to do from 60 kilometers or 50 kilometers away.
Sure. So can you hear me okay there?
Yeah, I can.
Great. So excellent question. So, and it really speaks to what our disclaimer for the day is, that what you do today before this webinar is the exact same thing you do after the webinar. So this recommendation has come out in the last couple of months, and we're looking at the time interval. Should we leave it at 30 minutes? Is it safer to do larger? For instance, some centers in Ontario do up to 60 minutes, and our colleagues to our east actually do 60-minute transport. So we know that it's heterogeneous what currently occurs. And is it possible to decrease this down to 30 minutes, or is that an application that only applies to the urban centers, like in the U.S. where you have 10 CAT centers available to you? So the answer to your question, Jamie, is you're following the protocol that's currently in place, and that's the correct thing to do for now. And if there's changes to come, it's going to come from recommendations such as these, but you're following the correct guideline right now, and you did the right thing. And it's kind of funny, it's a webinar phenomenon, but you sounded like a robot. So, but I think it's a webinar phenomenon. So I hope that answers your question. Interestingly enough, for our ACPs, the use of adenosine in patients taking carbamazepine or dipyridamol, which is kind of an aspirin with an attitude that's given to people with TIAs, is contraindicated in Ontario, but in the U.S. they advocate for half doses of this. I think more interestingly is that they're talking about adenosine now can be used for the diagnosis of wide complex tachycardia that's actually regular. So now we've always talked about narrow complex tachycardia for adenosine, but there are some centers that talk about adenosine being now used for wide complex, but the concern is that it has to be regular, because if it's irregular, you may have like a Wolff-Parkinson-White or a pre-excitation syndrome. You actually may precipitate ventricular fibrillation, which is less than ideal. Yeah, with adenosine, unexpected and less than ideal. And second thing, in really high heart rates, it's hard to measure if it may be slightly irregular or not. And I know that I was involved in a case where I gave adenosine, and then he went right into VF, and then I'm like, well, that was unexpected. And then immediately you defibrillated him, and he gets better, and he's like, what happened? I'm like, oh, you just died, but you're better. And I need a new pair of shorts. Bradycardia, so what's fast and what's slow. So pacing is now out for asystole, and I remember, I'm dating myself here, but about 7 or 8 years ago, we used to pace people that were recently asystolic. Let's hook them up to the pacer and see if it makes a difference. Well, that's now gone from the recommendations of the bradycardia. One thing we talked a bit about at research is, maybe the role of symptomatic bradycardia, instead of going with a pacer where it's so difficult because you have the transcutaneous pacer and the person's kind of unconscious because they're not producing their brain with a heart rate of 30 and a blood pressure of 70. You hook them up to the transcutaneous pacer and it starts hurting them, and then you want to sedate them because it hurts them, but then you're taking someone with a kind of decreased level of consciousness and sedating them more and worsening their airway, and then what happens is the pacer doesn't capture, and then you're kind of making everything worse, versus plugging them into dopamine, which then will bring up the heart rate, bring up the blood pressure, and maybe giving like a medication like dopamine may be better to pacing if atropine is ineffective. And so that's kind of an interesting school of thought, and maybe we'll see that move more to prominence in the new directives. But certainly that's always an option available to current ACPs.
And I like your disclaimer on the clip art there.
Thanks. Yeah, this is faster. See, I'm quite proud of that one. Interestingly, if you look at the algorithm, we're so specific about atropine being used only for sinus brady and also for first-degree AV block or second-degree type 1. But in the algorithm that the American Heart Association put out, atropine is the first line for all bradycardias. Now, agreed. That is, if you look at the wording on the recommendation, the caution remains in second and third-degree heart block, but the evidence for harm in that is low. So, yet again, nothing changes today with your directives, but we may see a liberalization of atropine and bradycardia as part of the new recommendations. It's unclear, and nothing changes today, but that maybe this is how we see evidence change what you currently do, and we spend hours debating as to what the role for atropine should be in the future. Really sounds exciting, doesn't it?
Mike, just before we move into the last segment, because I see that this is the last section coming up, we've got one question typed in talking about STEMI, and in this particular case, wondering in the arena of STEMI, does size matter? This paramedic read that the level of elevation does not correlate with size of blockage or severity of MI. Any thoughts on that?
I think that the level of elevation does not, in my mind, but the number of leads involved sometimes do. So, but yet again, I mean, if you have like a large, for instance, left anterior descending occlusion or left main disease, you may get SC segment elevation across the entire precordial leads, even extending out laterally, depending on if you have a dominant left-sided circulation. Versus if you have 1 or 2 millimeters SC segment elevation versus 3 or 4 in the same number of leads, I don't really think that correlates to the size of the infarct at all, because it may be a function of the amplitude of the actual QRS complex itself. That's an excellent question. I've never been asked that question before. Good question.
And I'm going to give Jamie a chance here again. I think everybody kind of heard Jamie last time, and he sounded either like a robotic or
a Cylon from Battlestar Galactica.
Pretty much. So hopefully, Jamie, if you've turned your speakers down a little bit, I'm going to open up your mic and we're going to see if it clears up a little bit.
Yeah, I turned it down. How's that?
It's better, but you still sound like a Cylon.
Okay, is there any change now?
No.
Okay.
No, he's still scary sounding.
Well, I think Mike answered my question anyways, just regarding the distance and feeling uncomfortable. It was, I still feel very uncomfortable bypassing this route to the hospital. That was the only issue that I had. But in both circumstances, they turned out fine.
Well, there's no question, Jamie, that STEMI bypass, and you raise a valid point, STEMI bypass is an anxiety-provoking thing, and it's new for all of us because we're now looking at acute MIs who are the sickest of the sick, and the evidence is not clear as to what is the best blend for the patient. Do you go to the local hospital, thrombolyse him, and then move to bring him to the cath lab later? Because if you look at the evidence for reperfusion, it's get the vessel open, and most of the PCI or the PLASTI data is driven by reinfarction. So maybe it's better to lyse him and transport him. But if you look at, if you can do PCI first with a very short timeline, like a balloon up in 90 minutes, then that is the advantage. Like that, they're definitely better off that way. But what you're feeling, that anxiety, is what we're tackling all the time, because people hear in the press that this is a great therapy that's available to all kinds of patients. And so more and more municipalities and politicians and public members who are well informed actually want this to happen for their region. And so what we struggle with is, what is the safest place to put a paramedic in? We want to be able to have this paramedic that is transporting this person now because of this policy that's come out, 45 minutes down the road to a different hospital in a different city, driving by current hospitals to get them that benefit. But that puts you on the rivet. And we know, looking at the evidence, especially in Ontario, 3% of these people suffer cardiac arrest, and up to 10% of them actually have a significant hypovolemic, or sorry, not hypovolemic, but hypotensive or bradycardic episode. So they're not entirely safe patients. So absolutely, this is an anxiety-provoking event, and the jury is still out. And I'm actually, at the level of the province, leading the task force on trying to figure out who should be bypassed and how far should we go. And we're taking the lead on this, and the jury is still out. We're just not sure. Excellent question.
It's an excellent question. It's such an issue here that we actually, some Mike and Adam and Dr. Heyman, Dr. Kate Heyman, one of the first-year emergency medicine residents, they're looking at these issues, these problems, and actually driving some research out of the London area, looking at adverse events in our STEMI bypass and trying to figure out, which patients are safe to go the longer distance, which ones shouldn't bypass, trying to figure out, should they be with an ACP crew versus a PCP crew. So this is some research that's being generated out of London, and down the road, hopefully we'll get some good data to help support some of the decisions we have here.
It's interesting too because it's not a. My concern is people are sometimes taking what we're saying the wrong way. Is I don't want. We have paramedics that seem to be thinking that, well, this is unfair that it's only available to our ACP colleagues. It's more the opposite. I don't want to put. I've actually talked to one of the service operators who said that our PCPs are worried about these people arresting in the back of an ambulance with them, and my point is, absolutely, I agree with them, and I don't want to put our PCP colleagues in a situation where you now have someone that has a heart rate of 30 and a blood pressure of 70, and we get better like that with a dose of atropine. But that's not available in their scope of practice, so why do we advocate to put the paramedic in that position? But nevertheless, if we know that this is going to happen incredibly infrequently, and the benefit is that more people are going to survive their acute MI if we do this in 30 minutes, it may be better to drive 20 minutes, if it's 20 minutes to the local hospital and 30 minutes to the CAT center, it's better to go to 30 minutes to the CAT center. And I agreed, it's totally the Wild West which is happening in Ontario right now, because with stroke, everyone follows the same protocol across the province. But with STEMI bypass, what's happening in one center is 60 minutes, what's happening in another center is 30 minutes, ACP only, what's happening in other centers is all over the map. So I'm trying to drive a process where we at Southwest are actually trying to drive a process which is consistent for everybody, which is our big, based on the best available evidence and the best guidelines. Trying to follow the rules. I know it's a novel concept. This is an interesting thing that we have these tiered response agencies and agreements which we have all kinds of other ancillary healthcare professionals and colleagues running across the town, getting there first to be able to apply oxygen to save lives ahead of us. And quite honestly, outside of diving to decompression-related illness, there is no benefit to oxygen administered and provided by first aid providers, and that is a guideline recommendation out of the American Heart. And so we're looking at the collision factor and the risk of transports of rushing large pumper trucks across the city to be able to get that oxygen 2 minutes before in chest pain. Well, there's no evidence for that, and this impacts when we meet with our tiered response agreements to be able to say, well, why actually are we doing this? Because we know there's harm here, and there's in terms of collision and risk, and without a benefit. And this is a very unpopular and difficult negotiation to have, because all of a sudden you drop someone's call volume by 40%. That is a funding implication for them as an organization. So, but we don't make the rules, we just follow them.
And I also believe in the recommendations. There's also in the ACS section, there's talk of not applying oxygen to those who are having STEMI unless they have low oxygen saturations or they're in signs of failure or cardiogenic shock. So again, something that's not going to change practice right now, but is out there and may be the way of the future.
Absolutely, and specifically on that with COPD, for instance, a study in the British Medical Journal recently which showed that an increased mortality if you apply 100% oxygen to COPDers. And so how do we translate that into your BLS tender for oxygen administration, and how do we advocate for change at that level? And it's such a really topical issue, because it's this kind of studies that come out that we need to try and look at what the current BLS principles are and say, do we need to modify these based on the current evidence? And although base hospital programs and physicians per se do not write the BLS manual, and we've not got those, it's an emergency health services branch in the MEMSO document. It's well, not a MEMSO, it's an emergency health services document. But certainly the expertise from the physician group has been asked to comment on some of this new evidence to be able to guide what the future iterations of the BLS manual are. So it's a cooperative effort for sure. We keep getting asked about tourniquets all the time, and whether or not they're going to make it into the algorithm. It's kind of interesting that outside the military use, there really is they're too variable in their manufacturing, and their application to be adopted for widespread civilian use is actually a recommendation from the American Heart. And it's fascinating. I include this because really this is amazing how the American Heart feels the ability to weigh in on so many of these different algorithms. And finally, speaking of the BLS manual, they talk about pressure points and elevation are not recommended to control bleeding. So although if you look compared to the BLS manual, there are comments about pressure points and elevation. And one of our first things we do when we bleed is we put elevated and put, and sometimes even advocate for if, I believe the wording in the BLS is if direct pressure doesn't work, then pressure points could be considered. But the American Heart says that these actually are not recommended. So this is another thing where the physicians have gone through and read the American Heart Association guidelines, and we make recommendations back to the Emergency Health Services branch with regard to the BLS manual, and then they can decide what they want to include in your future iterations of the BLS manual. So it's that cooperative effort we're talking about, but I find it interesting how this all works. A lot of our colleagues in pre-hospital care and as paramedics have military experience, and some of them with military experience talk about these type of topical hemostatic agents, and can we use these in the field? And actually, American Heart Association recommends against them for routine use. And I think it speaks to that the combat theater is a different environment than what we have in most urban centers in Canada. One could argue that in some of the urban centers in the U.S. it gets closer to mimicking combat theater, but currently in Canada, where we have a predominance of blunt trauma, the routine use of hemostatic agents, and yet again, this is an American Heart Association guidelines. Even with that center, even with those considerations of penetrating trauma in those major urban centers, we still have to get away from using these topical hemostatic agents. Red blood cell. Many of them. Quite proud of it. This one here with the pressure points, I actually had a young child with his hand up asking a question in class, but it got deleted. It's quite crazy, that one. I know. Well, here's one that actually, interestingly enough, we got a question about the specific thing from a paramedic, and I must say, I'll take the hit on this one. I actually said, no, we would never do that, but now the American Heart Association has actually come up with a very strongly worded setting that said, in the setting of anaphylaxis, BLS should immediately administer an EpiPen even in the setting of cardiac arrest. And quite honestly, I mean, this is completely, would have huge potential protocol implications. Now, again, let's go through the disclaimer. What you do today is what you did at 9 o'clock this morning. You're going to still do the same thing at noon. But if this gets accepted into the new guidelines, potentially this may be something you may see in the new iteration of the guidelines. And if you take a step back, this is really why when you see standards of care, if we base standards of care based on the AHA guidelines, the time interval by which we get these approved and trained into the new go-around new training cycle, we may have sometimes in the past have up to 2 years before we get this into the new training cycle. And so if you have a recommendation that comes out that's strong like this, well, the pressure's on us to get this out there. So nothing changes today, but we may see something like this happen in the future. So, and it's funny how what we thought was inconceivable before is now completely conceivable, potentially, from an American Heart Association guideline. So, and that's sort of pretty much what we were talking about. I mean, the changes to ECC through AHA guidelines, I mean, they're evidence-based, and this is how we apply them. We, as the Provincial Medical Advisory Committee, then take this list and try and figure out what can fit into a new ALS directive and what can't, and where should we best apply this? Should we discard it? Should we blend it? Is it possible or conceivable to be used by our paramedics? And then this has to go through provincial training, through the training cycles with regard to base hospital education divisions to develop this, and then our educators go out and teach you at the research. This is what you see. So you as an end user, you as the person on the street seeing the patients, you get this research once a year from us, but this is all the background, one small piece of the background work that happens to try and develop these new advanced medical directives. We agonize over them, we develop new protocols, and we figure out the best ways to teach you with regard to the new directives, and come up with all different case discussions and presentations, and it's an exhausting amount of work. So you see now what the glimpse is from the raw data we get, how we assimilate that into new directives. But then until you get the new directives, though, it's status quo. That's all I had to talk about, Matt. Any other comments or any other questions? We'd be happy to take them, and hopefully we ended close enough on time. We went a little bit over, so any questions we're happy to answer. Otherwise, we can you can go on about your day.
Yeah, actually, Mike, I've got one medic, Steve, who'd like to answer a question. So, Steve, your mic's open.
Hi, guys. Do I sound like a robot?
Yeah,
No.
No, okay, good. Whew. All right, Matt and Mike, thanks for an excellent presentation. It's a great great overview of the AHA guidelines and what's come out. One of the questions that I had, you talked a lot about amio, atropine, adenosine, but there wasn't much discussion about epi. And I just pulled up the Part 8, the ALS part on, or the ACLS part on epinephrine. It kind of shows it as like a class 2B, so it lumps it almost there in the same as autopulse. Is there any consideration or change considered for what epi's role is? There's not much here that shows. Actually, it shows there's no studies really that show epi versus no epi. Trying to take a look here, yeah, is there any changes on epi at all? Or?
Good question, Steve. So we deliberately didn't include epinephrine because there are no large changes to epinephrine use outside of the fact that, as we mentioned in the Oslo trial by Lars Wick, talked about no IV medications versus some IV medications, and that that included vasopressors such as epinephrine. And really, if there's no difference in survival with any IV medications, potentially there's a role you could conceive that you don't need to give a vasopressor. Then again, also in some of the high fidelity ACLS situations or scenarios, they talk about actually being much more aggressive with the use of vasopressor based on some small case series which actually looked at if you are running in a cardiac arrest in a trauma room like we have in some of our large urban centers where you have multiple hands. If you start an art line on these patients so they're getting CPR, and you follow their diastolic blood pressure on their art line. So with every compression, you can actually follow their diastolic pressure. You can actually see that you need a gradient to develop a coronary perfusion pressure of 20, and that effectively correlates to a diastolic blood pressure of 40 on the art line. And so they actually talk about a dosing of your vasopressor, i.e. epi or vasopressin, to be much more aggressive than the Q3 minutes we normally advocate to be able to get that underlying diastolic of 40 or an end tidal CO2 reading of greater than 20. So clearly, if that's a recommendation, that's never going to make it to the field, and so we didn't include that in the diagram here. But that's certainly one of the things we're considering when I run a cardiac arrest in our trauma center where we have 3 or 4 different skilled set of hands hanging around. We'll try and, in a PEA arrest, we're getting lots of CPR, I'll put an art line in them and I'll run their arrest as long as their end tidals remain above 20 or we can get a good diastolic blood pressure of 40, knowing that we're still perfusing their coronaries and still perfusing their brain, and I'll give epi-Q2 if I need to be able to keep that diastolic and know they're potentially salvageable. As soon as their end tidal drops below 10 or they can't maintain a gradient to give me coronary perfusion pressure, I'll abandon it. So short answer is not much changes for epi in the field. Some evidence suggests you don't need epi, but quite honestly, other conflicting evidence suggests that more epi is good. So that's why we left epi out.
Great, Mike. It's not so much a question as a comment. This just comes in from a medic that spent a lot of time as one who is teaching the whole thought about epi and IM or sub-Q injections. Just thinking about that point about the recommendation to give epi and anaphylaxis, and that's the last comment. We'll wrap it up after that one.
So the comment about using how you're surprised by the fact we're giving epi and anaphylaxis, Dave, or?
Yeah, just a comment from one of the medics who actually taught this for quite a while. So of course, like all of us, we got to get our heads wrapped around the new idea of like what would even be the point of giving epi, IM, or sub-Q when you've got no perfusion going on.
Yeah, and I think that in my mind, it may speak to the underlying pathophysiology of their arrest. Because in medicine, there are very few silver bullets, and in anaphylaxis, epi is a silver bullet. Like epi takes dead people and makes them good in anaphylaxis. It doesn't necessarily do that in the cardiac arrest from other underlying causes, such as cardiac. So it may be that, and I don't know, but it may be that this recommendation comes from the fact that so effective is epinephrine in the setting of anaphylaxis that we don't want to withhold it. But presumably in the setting of cardiac arrest, you're giving an IM or a sub-Q shot of epinephrine, given the perfusion to your muscles and the relative value of epi in cardiac arrest because of cardiac etiology, maybe the benefit's not there. That's why we don't see guidelines suggesting epi-IM for all cardiac arrest, but just for the anaphylaxis variant because of the silver bullet effect. It's a Lone Ranger analogy.
Great. All right, well, thanks, Mike and Matt. Much appreciated. It was a great presentation. Thanks, Stephanie, in the background for running some stuff, and for everybody who participated today. Not a flurry of questions, but obviously they were getting the information along the way, but some good discussions and some good points. So once again, just that thought that, this is a good introduction, but there's no changes to the directives. I think between the two of us, Mike, we've said that enough times today. No changes to the directives whatsoever. So we're going to bring this webinar to a close. And again, thank everybody who participated. Don't forget, we've still got more coming up. Already on the books for March. There's going to be a webinar on anaphylaxis, and also Matt, you're back again doing another one on pre-hospital 12 leads. So we'll be looking forward to that in March.
Dave, last thing I would say is no changes yet to the directives.
Yes, no changes yet, yes. It's in the works, though, just in case anybody thinks that there's nothing going on. Let's make it very clear that there's been hours and hours and hours of work pouring into this for the last many months. So there's no changes to what they're doing yet, but the directives are in development. We're actually hoping that we'll see those by the fall of this year. That's the goal, correct?
Excellent.
Yeah. Good. All right, anything else, Mike, Matt?
Nope. Just a great thanks to everyone who participated today, and another example of how we're trying to reach out and get everyone involved with rounds and academic-style activities through the base hospital program. So thanks for joining us today.
Okay. Thanks, Alan. We'll see you again.